The Dan Yorke State of Mind program is brought to you in part by Lookout Rhode Island and Takeo Comfort Solutions.
Good evening and welcome to my State of Mind. I am Dan Yorke. Omicron is surging and hospitalization capacity is teetering. It has been for weeks now. What is the real truth about this from the inside? Tonight we talked to Dr. Jim Fanale, the CEO of Care New England, who's got a lot on his plate, not only managing the healthcare system, but working on a merger, which we'll touch base on later in the broadcast. So much pressure, so much going on, and so many folks who have different views about what the numbers really mean. Let's start with Governor McKee's visit to Lifespan, a soon-to-be likely merger partner for Care New England, and we'll pick up the conversation with Dr. Jim Fanale right after that.
What we saw was exactly what's being described, is this stress and this pressure.
Governor Dan McKee visiting Rhode Island Hospital's emergency department Tuesday, seeing firsthand the effects of the latest COVID surge.
The description that we've heard from the, from the emergency physicians as well as the head nurse that was walking us through, they were certainly describing a stressful issue. It's stressful because of staffing.
That's why the state is now in talks with the Rhode Island National Guard to send in reinforcements. Approximately 180 National Guard members will be sent to testing sites, vaccination sites, and hospitals to lend a hand.
We've been in discussion with the general, and we thank him and the Guard again for stepping up in a way that I'm not sure that they were really expecting, right?
Hospitalizations aren't yet where they were this time last year, but staffing levels are crumbling the state's hospital system. Right now, Rhode Island Hospital is over 100% capacity.
They're about 113% of capacity, but the capacity is about 65% of their normal capacity because of staffing.
To provide some relief to emergency rooms, McKee said his team is looking into opening more urgent cares and expediting the discharge process.
Talking to the insurers about how we can release patients on a more timely basis when they're ready to go home.
McKee said a majority of hospitalizations are those unvaccinated. The governor had this message for them.
You made your decision. We respect it, but you need to take special care and be in quarantining yourself to a degree right now during this spike in infections because you are very, very vulnerable.
And as promised, Dr. Jim Fanale from Care New England joins us. Probably too late to say Happy New Year, but I have to ask the question, Doc, you've always been incredibly candid. Is anything happy right now? It feels like this is nothing but a stress convention.
Well, it is, but this is what we're supposed to do. We're supposed to take care of people. So I said to people this morning in a sort of a pep talk arrangement, we still have the best job in the world. People looking for us to take care of them. It's going to be hellacious and tough, but at the end of the day, people are going to say thank you, and we're going to know we impacted folks. So I'm usually a half empty guy, but I got to kind of make it half full, or not more than that.
All right. A lot to cover. We just looked at a news piece where the governor, visited Lifespan, formerly your kind of competitor, almost your partner. We'll talk about that perhaps by the time the broadcast ends. But, he has recognized what has been called for, which is a need to support staffing out on the operational side, on the revamp, if you will, of booster shots and testing. But it seems clear the nurses union and others have asked for that kind of support inside the hospitals and key medical facilities because you're just strung out. Do you support that, and do you need that at Kent Hospital and the other facilities that you manage, women and infants, Butler, all that?
Yeah, well, we need a lot of help. I mean, I think that the staffing woes, remember, we started with a baseline lack of staff or reduced staff and vacancies everywhere. And now the Omicron variant's causing a significant amount of illness. So it's impacting people's ability to get to work and work every day. So the staffing crunch is huge. On top of that, the costs that we're incurring are just enormous. I would say year over year at Kent Hospital, for example, it's about $2 million more per month just to pay for the staffing, because of agency staff and overtime, et cetera. And just so you know, the reimbursements aren't going up $2 million a month. So we're in a negative financial position. I heard somebody yesterday say, gee, and there's a national story about our hospitals milking and admitting everybody. You know, Dan, right now, I'm losing on every case and making it worse by volume. Because every case we don't have a margin on these stuff because staffing costs are high. Patients, instead of being in the hospital 3 days, are in 8 days. So it's really a challenge.
And you're not, you know, people who get injured or need procedures never view it this way because, you know, medical product is life-saving or life-enhancing, but their money, their cash flow. So the other surgeries, the other stuff that you've now had to move and postpone, which for your purposes are to improve people and help save people, but also are cash flow tools, right, aren't happening or have been, you know, elective processes, right?
So you're right. I mean, those are generally margin businesses and margin products, I'd say. So right now, we look at them as cases that require an overnight stay, rather than look at elective or emergency. It's cases. So we did 2 yesterday. They're cancer operations. So what we're doing is the only ones we're doing that require overnight stay are ones that are cancer operations. So you get diagnosed with colon cancer, lung cancer. You're not waiting 2 months to get done. We're going to get you in and get that done. But total joints, bariatric surgery, et cetera, we are putting off. It makes the patients are upset, surgeons are upset, but those are the only cases we do. So we had none yesterday, we have 1 today, and those are the cancer operations. And now we're going to stop the other cases that we're doing for a while. Every week or 2, we're making a decision, Dan, based on staffing. So those 20 or 30 cases we do, which are, you know, bunions and orthopedic procedures and scopes, we're stopping them for a couple of weeks because we got to take that staff to cover the rest of the hospital. So yeah, that adds to the financial woes, quite frankly. All
right, so, you know, we're going to pause here, and when we come back, we're going to talk about what is the truth on the staffing. There are a lot of folks who just that have their own interpretations as to what this staffing deficit is all about. Dr. Jim Fanale, the boss at Care New England. When we come back, stay with us.
Omicron variant is spreading very rapidly. It's obviously very infectious. The good news is it doesn't seem to be as severe, but we still are not trying not to have healthcare providers working when they are infectious. We may get to that point if there's significant further spread. We're not at that point right now.
Back with Dr. Jim Fanale, the CEO of Care New England. That's Kent Hospital, Women and Infants, Butler. The question of staffing has got a lot of people confused. And there's a lot of controversy that surrounds it. And there are a lot of folks who'll call my radio show and say it's the vaccine mandate, and they're lying to you about this 1% that didn't take the vaccine. Is it true, by and large, or specifically to your organization, that your staffing is down 30%? Is that the number? Because we hear 70-30.
No, I don't have the exact number, but here's what I can tell you. So in various departments, the vacancy rates are extraordinary. So let's look at the ED nursing staffing in Kent's emergency department. We have a vacancy rate in the 40% range. So 40 to 45% of the nursing staff is vacant. And the inpatient side of Kent is in the 30s. This is not taking into account illness that causes other people to go out. So that's the base staffing number. And that's why we're using all these agency staff, some 60 agency staff in Kent or more. And we're using, asking people to do extra shifts. Everybody has this float pool or per diem pool. Our float pool and per diem pool are working all the time now. So that's sort of where we're at in terms of vacancy rates on med-surg hospitals. And I think that's consistent probably at Lifespan and other places.
Okay, so reconcile for me the difference between I'm sure your honest assertion that 99% of the personnel finally did vaccinate at the vaccine mandate for healthcare workers, yet you're down another 29, 30, 32, 37% on the staff. What is that gap?
What do you mean about the number? What's the impact of the unvaccinated?
No. So simply said, you're down, you just told me you're down 30, 40% across the board in these acute facilities. Yet those but you had a 99% vaccination rate.
Yeah.
So you've got an attrition that is due to what? Fatigue, burnout,
Yes.
income, blah, 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 da, 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 right?
Right.
And that's devastating, I think, to hear that the industry has been so hurt. Well, who didn't think that if you wind the clock back to March of 2020, that was the beginning of, let's not forget how hard 2020 was.
Yes.
We might have had a little better 2021 in this gap
Yes.
between the variants, but right now it's like, oh, holy cow, you're seeing the long-term effects of people being exhausted, quitting, demoralized, depressed, all of those things, correct?
It is. So that's the baseline. So you went from okay staffing in 20, people burned out, whatever, and then this boon in agency. I mean, I understand it, right? All of a sudden, agency becomes supply and demand, right? You need agency staff, where we used to pay 2x for an agency person. They're able to accommodate and get 3 to 4x and pay the nurses 2x. So I don't blame a nurse who says, listen, I got debt. I'm going to quit my job and go work for an agency who can pay me more.
Yeah, I want people to understand what you're saying. So there are people who are full-time veterans, perhaps hospital emergency room nurses, who work for X, but because the federal government has supplied a lot of the money on COVID for these temp agencies for nurses or these traveling agencies, they leave the full-time employee of your hospital and go to that place. And what used to be a travel around New England type of thing in order to get the work now ends up coming right back to the place that they work originally, correct?
Yeah, I mean, when we used to hire 68, remember we had a lot of agency staff to staff the field hospital. Those people generally came from out of state.
Gotcha.
Okay, that's travelers. I would say of our agency staff, I don't quote, you'll quote me on the number, but it's probably 40% are in state now that go to work for agencies. And I can't blame them. I get what happens, but it's been a real financial delta.
But they work anyway at an extraordinary multiple of cost for you. And that, we'll have to figure out your math. I'm guessing that the hospital system has a pretty good credit line, because you guys you almost got it back to somewhat normal. I mean, I remember the days prior to COVID that we talked about how well you've managed your finances at Care New England, and you were battling to say, you know what, I can do this on my own. I don't need Lifespan. I don't need the big brother. Well, COVID blew up the whole industry. You're now merging for reasons that have nothing to do with COVID, but what a mess. I wouldn't want to look at your books on a last 3-year basis. It must drive you absolutely crazy. But I guess the bottom line here is that in addition to your financial woes, which are a given, and I wouldn't want to be nonchalant about that, what we're trying to figure out is, what do you do to fix your staffing issue? What is it that is the solution? The governor says, look, I got a problem here with the federal government. They're front loading dough to these traveling agencies. It's hard for us to compete with that, but we're going to try to get them to stop that. Well, that's moving the Titanic. I don't know how that's going to happen quickly. What is it? The National Guard comes in and says, okay, I'll roll the wheelchair so you don't have to, right? I mean, that's kind of what we're talking about. So you're worrying about just getting shots in arms or IVs running, or will that help your ability to get the job done?
So let me tell you, we're not going to replace the vacancy rates in nursing staff for probably 3 years. We're not going to get caught up in 3 years because we need more graduates. What do? One, we manage our throughput and our patients as tightly as we can. So, if normally you're in the hospital 4.5 days and safely go home in 4 days, that's what we need to do. Number two, we need to look at different models of care, look at the staffing ratios. Can this technical staff person help augment nursing so we can fulfill that need in a different way? So we're looking at all different kinds of models to staff emergency rooms, inpatients, et cetera. And are there ways to take off the loads of the nurse so that we can augment them with other staff, lower level clinical staff, MA, medical assistants, certified nursing assistants. We have to look at the models. How can we use EMTs in emergency rooms, et cetera? So we're looking at the models, we're pushing the models, we're trying to be as efficient as we can in the throughput, making sure only those people that need to be admitted get admitted. We started a hospital home program today. We now have hospital level of care patients at home. Nursing requirements different. I mean, we don't have to have 1 nurse to 4 patients. We're doing stuff telephonically and telemedicine wise. So all different ways of caring for patients that are safe.
Okay, so I mean, let's put it this way. What used to be a capacity quota is not a capacity quota now, because the analogy is if you had a restaurant that had 100 table capacity, and that was a sellout, fine. Now your capacity is only 70 tables. So that's a different sellout ratio. So obviously the building itself is not being fully utilized and won't until this whole thing evens out over the next few years. Tell me though what the break point is, if at all, on the number of patients that you have in there COVID wise. Obviously this Omicron thing is requiring less and less occupancy for hospitalization prorated and less days prorated. It seems to be pretty clear, but this number keeps crawling up, 300, 350. Are we near auxiliary need? Or do you think we're going to be able to manage this whole thing without additional hospital facilities?
So the limit, so remember, more people getting affected, less getting hospitalized. Delta, less people getting affected, more people getting hospitalized. So it might turn out to be the hospitalization numbers will be the same, even though it's less virulent, right? Because of the sheer numbers. So I don't know that yet. We'll know that in a few weeks. That said, our capacity issue in terms of number of beds is limited by how many staff we have to put in those beds. We could have 230 inpatient beds today. My inpatient beds are in my emergency room today. So I may have 200 patients in the hospital, 40 of them are in an emergency room bed as a hospital patient. So what I'm telling you, we're boarding people in the ER, holding them till we get a staff bed upstairs. So our ER is backed up with people that can't get in to be seen. So we are not, we're managing day to day, Dan.
Right.
I am confident that if the state hospitals pull together and we all work together, we'll get through it, because we always have. If you ask me, what's the break point? We're not there yet. Some hospitals are more stressed than others. And we got to serve the public good. So we will have to figure out a way to get through it if it gets worse.
All right, and so the other question that lowers the Department of Health allowed for, and Eleanor Slater utilized, I think, for a day, COVID positive nurses to come back under an emergency situation. And then there's a question of whether the unvaccinated 1%, we've made our point, can you bring them back? I know you're staunch against bringing the unvaccinated back, correct? You don't want to do that.
No, we're not going to do it. I mean, I think that, of the less than 100 that we lost, some were clinical, some were not. I think vaccines provide more protection than people say, well, they got the disease, aren't they protected? Yeah, kind of, but they're not as protected as they are vaccinated and boosted. So we're not going to do that. I think that the Department of Health is saying, if you're asymptomatic and after 5 days, you can bring people back. So can you bring an asymptomatic COVID positive patient to work in your COVID unit? Yeah, you can. Okay. So I think they're trying to be incredibly helpful and relaxing those things in crisis kinds of situations, which we may head to.
All right. When we come back, we'll talk about the big picture, whatever that is. Stay with us with Dr. Jim Fanale from Care New England. Back with Dr. Jim Fanale from Care New England. We could talk all night about this hospital staffing issue and the like, but what used to also take a show or two or 10 is the merger with Lifespan. Some new information has come out from the Attorney General's review about Brown's disposition on all of this, and they were more clear in a Boston Globe article that I saw this week about the academic application to a merged group here that would be much cleaner. So to me, I read it as cleaner, more efficient, no conflict. That sounds like a good thing. The synergies seem to be much more easy from Brown's perspective with this merger between Lifespan and Care New England. Do I read that right?
Yeah.
Yes. Okay.
Yeah, I mean, Brown, remember, is not a. Yeah, Brown's the academic partner. They're not part of they're not an asset share. They're not part of the business. But yeah, they're clearly going to be an academic partner that's helpful to build this system that we want to build.
Well, they already are, but they're saying it's going to be easier, and sitting on boards will be easier, and split consciousness and competitive issues won't be getting in the way. No conflict. Where are we, by the way? We only have about a minute here. Where are we in terms of the timetable on the merger?
Getting down to the end of the game, regulatory process finalizing. Another week or 10 days of depositions, which is the Attorney General and the FTC are interviewing folks, getting more information. We think the FTC sometime the end of February will rule as whether they're going to sue to block this merger or not. And the AGs and DOH has till mid-March. So we're getting there, and we're getting down to the end of the road here. So we'll know soon.
This is, with what you're dealing with, this is the ultimate high pressure walk and chew gum at the same time, isn't it?
Yeah, so there's a handful of us doing all the merger work. We'll take care of that, folks. Let us do that. And there are more than a handful, but we've tried to limit the number of people that had to do that work so that we'll just take it on ourselves and keep them informed. All
right, listen, good luck. Keep smiling, stay half full, and one day at a time. The sentiment though is, as you've so articulated often, thank God for hospital workers. Thank God for the men.
All of our workers, back office, HR, everybody's pulling together.
All right, final word when we come back. Stay with us. The moral of this story continues to be, get your vaccination, get your booster, and get a really good mask. And we'll get through this one day at a time. Happy New Year. We're here weekdays 3 to 6 on WPRO as well. Talk to you next week. Good night.